Okay, wonderful. Good afternoon to everyone. My name is Marjorie Tingle, and I will be your conference administrator for today, along with Ms. Trinice Beaver. Today, we are so excited to have with us Dr. Simone Uwan. She'll be speaking on treatment options, exchange transfusions. Welcome, Dr. Uwan. We're so glad that you were able to make it today.
Thank you. Thank you very much. I am excited to actually, can you guys see me and hear me okay?
Yes.
Okay. I'm excited to actually do this because this is personal to me. So I am not only a physician, I'm a patient. And so everything that I talk about, is basically my life. So
hold on 1 second, Dr. Simone. Sorry to cut you off. Can you see it recording?
I remember it saying recording, and I had to give permission to do that. So.
Okay, but did it start? Because we just want to make sure it's being recorded. And I just gave you host privileges, so I can't see that.
Okay, so how do I see that? Let's see. Oh, yes, it says pause or stop recording, which implies that it is recording.
Okay, thank you.
No problem. All right, so I am going to jump right in because I know that we are, this will stop other screen sharing. Is that okay?
Huh?
It says this will stop other screen sharing. Do you want to continue?
I don't know what popped up.
Okay, let me see. I hope that this is all okay. And let me see. All right, and let me see if I have what I would like. So can you see my screen?
Yes, I could see your screen.
Okay, awesome. All right, so I'm gonna go into slide mode, and anybody that comes in, I will let them in.
Okay.
So I wanted to start by telling you guys a little bit about how I got here. So in November of 2018, after having a huge shift in my life, right? I was practicing, and then all of a sudden I got sick and I felt like my life broke. And I still to this day consider that my desert moment or my desert season. And I had to kind of restructure myself because I was a clinician, and I enjoyed being able to practice medicine. And all of a sudden, I was doing nothing. And so I had in my heart for a long time to write a book. So in November of 2018, I wrote this book. And so my little book, which it is really little, it's a very quick read, was called A Doctor in a Patient's Body, Dreaming Big with Sickle Cell Disease and Chronic Pain. And I just shared my life. And something really amazing happened. It became an Amazon #1 bestseller in 6 different categories, actually. This one is hematology, but it was also like alternative medicine, genetics, and memoirs, and all these kind of things. So it was really cool. And so me with my big mouth, I wanted to celebrate. So I went on Facebook and I went into all of the sickle cell groups, and I said, my little book. And it actually became #1 in France and in Canada. So it made me international. I was so excited. And when I started talking, something happened. I started getting an influx of mail, like messages, and people going, Dr. Uwan, congratulations, but like, where have you been? Like, we need you. And, you've just been hiding out, and you've been selfish, and we need your help. And so it was a huge like awakening for me, because I thought I would just write a book and then disappear. So I ended up all of a sudden having to go public. I had been a sickle cell advocate in my little private world. I saw sickle cell patients in my clinic, but all of a sudden I was like on a public stage trying to advocate, wet behind the ears, trying to figure out what I was going to do. And I was still pretty sick. But the one thing I kept hearing in the community was that there was a gap between the patients and the doctors and the treatment, for their pain. And I wanted to find a way to bridge that gap. So within a year, I ended up writing a second book, and it's called All Rise, the Sickle Cell Community versus the Medical Establishment. And it also became an Amazon #1 bestseller in medical education and training. And I think it was genetics again. But I started to attend conferences and things like that, trying to, spread the word and trying to bridge the gap and trying to talk to doctors and all that stuff. And then I realized that I wasn't well enough. Like, the whole reason why I stopped working was because I wasn't well enough to do a lot of things. So I started exploring exchange transfusions, and I had exchange transfusions for a period of time in my life right after my diagnosis, and it really had helped. It was after I had acute chest syndrome, and I was transfused for like a year. And so I thought, that was one time that I felt like Superwoman. I felt like I had all this energy, and some things had happened that made, I moved, I went to medical school. A lot of things happened where I never really revisited it, but now I was forced to find some energy since I was going to advocate, right? So that's what I want to talk about today, how I ended up with exchange transfusions and how I made it applicable to pain and pain management. So we're going to start with that, but first I'm going to go through some definitions because it's important that you understand it. Is going to come up a lot. So the first is immunity, and that's like your body's ability to fight off anything foreign. And foreign things are called antigens. And I tutored a lot in school, so I would tell people things like, the antigen, think, okay, hold on, I think I see, is that people that need to come in? Okay, no, okay. Oh, here we go. All right. Where was I? Oh, so I would tell people ways to remember things. So like antigen, I'd say, think Auntie Jen, like you had, an aunt named Auntie Jen, but you're not welcome here because you're gonna mess up my flow. So if you want to think about what an antigen is, just think Auntie Jen, you're not welcome here. That's just a little tidbit. And oh, my thing is suddenly not wanting to advance. So let me just go out real quick. Why is that happening? Okay, there we go. Okay, so another definition that we need to go over is Aloe immunization. So Aloe immunization is like a trigger of immunity that your body does in response to these antigens, right? So when the body is exposed to any foreign cells from outside, from like another person, like say you're donating, blood or organs. In this case, it's red blood cells, right? Because we get donor red blood cells. Whenever that happens, there's a triggered response, and it's called Aloe immunization. And it becomes a complication in blood transfusions, especially when you're chronically transfused, and that's why we have to talk about that. And then the other one is called autoimmunization, and that's the body's response against its own tissues. So if you, I'm sure you've heard of people that have like lupus and other things that are autoimmune. So people like that, if they have transfusions, they usually will have a higher rate of breakdown of the red blood cells, so they will require like immunosuppressive drugs or other alternative therapies, like say a shot of steroids to kind of calm things down at the time of their transfusion so that it goes well. So let's talk about why we even need a transfusion, why I needed a transfusion. So sickled red blood cells are sticky, and they encourage vascular or blood vessel changes that promote blockage. They increase the thickness of the blood, the viscosity of the blood, and they cause abnormal interactions with your white blood cells and platelets, and even the insides of your blood vessels called the endothelium. And I'm sure with the new therapy of like Adakveo and things like that, you've heard of like p-selectins, and it's like little pieces of Velcro on all of these cells. And that's what the sickled cells do. They kind of cause that to happen, and then everything is sticking on each other, and it's causing blockage, and that's what results in pain and organ damage, because you don't have blood flow to organs. So transfusion of donor red blood cells is used to lessen those effects, right? And so over the last 30 years or so, there's been a lot of evidence that indicate that an exchange transfusion, also known as a red cell exchange, has value in mitigating that. And let me put this over here because it's partly blocking my, there we go. Okay, there we go. So the most common indications for transfusion in sickle cell disease is prophylactic, so preventive, like if you're going to have a surgery, making sure that you're adequately prepared, you have enough circulation, and you don't, if you bleed out, that you have enough to replace it. In the setting of a stroke, you would have transfusion therapy there. And then if you have multi-system organ failure, that's a big indication, to come on in and just replace the red blood cells to kind of stabilize the system. And the same for acute chest syndrome. Anytime your body has a big shock or a big trauma, you're gonna see that red cell exchange or chronic transfusion is going to be indicated. And then, chronic occurrences like stroke prevention in kids, which, I think extends to adults. The less common off-label indication is chronic debilitating pain. Debilitating means causing weakness, like, it weakens your system. And we can all agree that sickle cell crises causes debilitating pain. And they say like a third of us end up with mild chronic pain, a third with moderate, and a third with severe, right? And so that's a big population that's having chronic debilitating pain. And if you are at home and you're having pain medication for your management on a daily basis, that's because you're having debilitating pain. But this is not well known. It was kind of hidden. And I was, after I started doing this, public advocacy, I needed some blood, I needed some help, I needed something. And I was using a lot of already natural things to help me, and it wasn't getting me exactly where I needed to be. So I started reading everything. So I read the expert panel from cover to cover that was published in 2014. And this was like 2019 now. So we didn't have the ASH updated guidelines. All we had was this 2014 expert panel, and then this book, which was 10 years before that. And it was from the NIH, the NHLBI published it, and it was for the management of sickle cell disease. And it was, and so I was reading this book, and on page 154, chapter 25, right? they're in a little teeny paragraph, right? It said, chronic transfusion, it may be used to treat chronic debilitating pain. And so that's why I said that's an off-label use, because at the time, nobody was doing that from here in Orlando. Nobody was transfusing people because of pain. They were only doing like the traditional reasons, like, you know, stroke prevention or reoccurrence, acute chest, and all that stuff. But nobody was doing it for chronic pain. So I had to go searching to kind of persuade my doctors, right? So it was like a needle in a haystack. Here's here's page 154. And I blew it up and took it to my doctor, and I highlighted the little paragraph that said, chronic transfusion therapy at the top. And then in little, line saying it may be used to treat chronic debilitating pain. And I took it to her. It was like a needle in a haystack, but I found it, right? And so I was so excited because they received it well. And, and I went over with them. I'm like, this will benefit me because, number one, it increases the percentage of red blood cells, that have normal hemoglobin, right? Because those are the donor red blood cells. And it increases the amount of red blood cells you can give without increasing the hematocrit, because in this procedure, instead of like the simple transfusion where you just give more red blood cells on top of your blood, this one removes, through a special process, removes your blood, takes out your red blood cells, right? And then puts in the equivalent amount of donor red blood cells in your blood. So there's no extra thickening or there's no iron overload to worry about, because it literally just exchanged like apples for apples. And so because of that, you don't have to worry about it getting thick. You don't have to worry about iron overload. When people get the straight transfusions, they need an MRI like every 1 to 2 years just to check for iron overload. So you wouldn't need to worry about that. And it protects the organs better from ongoing damage from your red blood cells. And if you get exchange transfused, and I actually needed to credit, I need to update this because I need to credit Dr. Ifyosunkwo, who provided this information. But if you exchange transfused during a crisis, you're going to be at the same risk of Aloe immunization as, if you are going through a simple transfusion. But if you do it preventively when you're fine and you're just doing it regularly before you get a crisis to prevent the recurrence of your chronic pain, then there's actually less Aloe immunization happening. So this is all, good. I mean, it doesn't mean that, you don't have any Aloe immunization because you're exposed to donor red blood cells. And the challenges are also that you need a special equipment. So it looks like it looks like a dialysis machine that you are attached to. So it's not like, and it's called an apheresis machine. It's not like what you do for your simple blood transfusions, right? And you also need a special access. So, I could show you mine, but it'd be inappropriate, but you need a special port that would attach and accept high volume flow, because you're doing like, 8-9 units of blood at a time. And it's a procedure that when it's done, it's probably 2 hours. Whereas normally 1 unit could last, 2 hours to be transfused. So because of that, you need either like a double lumen power port, or you need a central line catheter, which I tended to do a lot because you can just put it in and then take it out. And there are There are permanent ones as well, but that was my choice. I just didn't want an indwelling line, because then that creates possibilities for infections and things like that. And I've had 5 hip surgeries. I've had infections in my hips. So I don't want any infection in my body, to my hips or otherwise. So I chose to do it that way. There are ways to lessen your post-transfusion aloe immunization. And again, this is popping up. So am I admitting somebody? Here we go. Yeah. Okay. So there are ways to prevent post-transfusion aloe immunization. So the red blood cells, the donor red blood cells are screened so that you're not getting any sickled cells, like say a sickle cell trait person donated blood. You're not going to be getting that, right? Because it's going to it's not going to give you as much of a relief. So they make sure that that's happening. They also do a filtration to remove donor white blood cells, and they also irradiate the blood so that whatever might be left over becomes inactive. Like if any residual white blood cells are still hanging out, they would become inactive. And then they match it. They make sure that any antigens that are on the cell surface, that it's matched so that you're not experiencing anything foreign. And again, hold on. Is it because I did this? Okay, I think so. All right. So ASH 2020 guidelines for transfusion, they actually recommend that you prophylactically match for those give me a second. I think somebody else is wanting to come in. And I want to make sure everybody, oh, it just happened there. Okay. So yeah, they recommend red cell antigen matching for patients with all genotypes of sickle cell disease receiving transfusions and immunosuppressive therapy. It doesn't have to be things like rituximab or eculizumab. Those are later on if you really don't respond to like a dose of steroids before your blood transfusions. And but they do recommend having, if you're going to do long term, having that done right before, like about half an hour before is when I was given my steroid shot. And then they actually say if you're going to get chronically transfused for any reason, you should get exchange transfusion versus the simple transfusion. And they themselves recognize that you are in a better situation if you are exchange transfused, because you're getting more benefit, number one, because you have all of your sickle cells removed, and then you're getting donor cells, and they have a criteria that the sickle cells should be between 30 and 50%. Most people try to get it to 30, or most hematology specialists will try to get it to 30%. And so because I'm SC, they would want the S and the C to be at 30% or below when I was transfused. And that is it. These are my references. And that is everything. So I tried to be quick. I know I kind of ran through things, but if anyone has questions, I'm going to end the sharing so that I can see you all. Okay. And let me see if I can. can make this wider again so that I can see everyone. Okay. All right. So does anyone have any questions? I'm trying to still make this bigger.
If you have any questions, kindly put them in the chat and we'll be more than happy. Dr. Uwan, we appreciate you so much. Dr. Uwan will be more than happy to answer those questions for you.
I'm so sorry, guys. I'm trying to go to the, oh, okay, you are screen sharing. Stop share. Okay, that would be good. That might help. Yay! All right. All right, so let me see if there are any questions. I don't see any. Do you?
I don't see any. Nope.
Okay.
You can also look in the Q&A. There might be one in the Q&A.
Okay, let me check and see.
Oh, there's a question in the chat now.
Oh, okay. Yes, one of
Oh,
the,
yes. Yes, both of my books are available on Amazon. And if you email Dr. Simone Says and request a book, I can send you an autographed copy for the same price. Yeah, but they're both available on Amazon. And the amount of blood used is dependent on your hemoglobin, right? So yes, so they try to match it, you know, so that you're not necessarily getting an excess, because remember, if you start getting an excess, then we're starting to talk about things like iron overload. What we're trying to do is kind of replace it pound for pound. So whatever your hemoglobin is, whatever your hematocrit is, you know, your red blood cells, the percentage of your red blood cells, they want to take that out and put in donor red blood cells in its place. If they go above that, then it's like getting a simple transfusion, right? Because you're getting more than you had. And then you start, your body starts being stressed, your liver starts being stressed for iron accumulation. Now, if you have that, you know, once in a while because you went like super low and your own hemoglobin went super low, and so like you needed a boost, then, you know, that's not going to be a problem. I think it becomes a problem if, you know, each and every month that you get your exchange transfusion, you're super low and needing to get more than you had. So what they would do is, if you're low and you're kind of trending low all the time, then they would try to do other things to increase your red blood cells. You know, first, you know, of course, natural things, and then things like there's something called EPO or erythropoietin or epogen. They're all the same thing. Things like that can boost your red blood cell production. It's naturally made by the kidneys, but sometimes with sickle cell, especially if you're having kidney complications, that can be suppressed or depressed. So they would give it to you, you know, as a medication to stimulate the production of your bone marrow's red blood cells. And so so yes, it does depend on your hemoglobin. What if you have immune thrombocytopenic purpura and acquired hemolytic anemia problem with your platelets? So those are specialized things, right? I'd have to go like, read up on that. But my natural thought is that you'd have to have a talk with your hematologist about a strategic plan forward if you need to be immune suppressed, like, whether it's a dose of steroids or in a case like this, especially if you have acquired hemolytic anemia, you're likely having auto immunization, right? So you're making antibodies against your own body, and you're breaking down your own red blood cells. Oftentimes, what they might do is do something like a splenectomy to lower that, but otherwise, that would kind of be the way to go, is to kind of stabilize you so that you don't have any more breakdown, and then transfuse you if you need it. Anyone else? You guys are quiet today. All right.
I have a question, Dr.
Yes.
Simone. This is Carla. There's another question in the in the Q&A in the box, but one quick question I wanted to ask: what should patients know if they, because we always talk about self-advocacy and also patients being aware not only of their history, but being aware of the process of what should they know when an exchange is introduced to them. Some may be hesitant, but what should they know, and what's some of the questions that they can ask so they're making sure that they are getting the adequate care possible when in need?
That's a very good question. One of the things I had to learn is call the blood bank and ask, not the blood bank, the lab, and ask them for a, actually I did call one blood, but ask them for, do I have antibodies? Like, do I have antibodies that when they give me blood, that they have to look out for? Because I want to make sure that if I'm in another facility that doesn't know me, or I'm dealing with another doctor, I'm thinking this is kind of run-of-the-mill stuff, but I'm realizing that in certain hospitals it's not. And ASH 2020 actually recommended an extended panel of screening for all of those surface antigens, even some of the rare ones. And a lot of times when they give us blood, whether it's simple transfusion or exchange transfusion, they will do the typical screen for what they would do for any patient that's receiving a blood transfusion. Well, we are by no means typical. We're going to have this chronically, and if we have it chronically, we're going to be more likely to generate antibodies. So we really have to know, if they're screening with an extended screen, like, are you screening for all of the, the rare types? Because ASH 2020 guidelines say that you need an extended screen, not just a screen that you give for all of your patients. So you could ask them, you can just ask your doctor directly about that. Like, what kind of screen are you doing? Is it the regular, type and cross screen? Because for me, I need an extended screen for all of the rare surface antigens, because I'm going to be doing this repeatedly. So I'm going to be at risk and I'm getting larger amounts of blood. So I'm going to need to have a really good screen. And you need to know that they're, irradiating your blood, that your blood is, usually if you have a hematologist that knows about sickle cell, they know not to give you red blood cells from a sickle cell carrier, right? That has some sickle cells in it. But, it doesn't hurt to just put it out there and be like, it needs to be sickle negative. It needs to be, irradiated so that, all of the lymphocytes or the white blood cells from the donor is gone or inactivated, so it can't hurt me. And it needs to have an extended panel so that everything, every surface antigen is checked for, so that I have the best shot at not having any antigens that my body now has to fight off. So I think those would be some good places to start. Getting asking about your own antibodies that you may have had from previous transfusions, knowing those, so that if anybody wants to transfuse you, you tell them, like, I have these antibodies, and so you need to check. But if they're doing an extended screen, that should cover any of your antibodies that you would have. So that's what I would say. And it doesn't hurt to, if you're doing this for pain management, which is why I wanted to show you the picture, of that book that was published in 2004, Management of Sickle Cell Disease by the NHLBI. And, it doesn't hurt to have page 154 with that little paragraph highlighted, because that's exactly what I had to do, because they weren't accustomed to doing that here at Orlando Health. So I actually had to make my case. And so it doesn't hurt to walk around with your information so that you have it and they know, that you're paying attention, so they pay extra attention too. I think I see, okay, does oral therapies or crizanlizumab help reduce your transfusion need at all? That's an excellent question, and yes, it does. So crizanlizumab, I actually started last year. I started like in May or June, stopped because of the pandemic, and then restarted in October. And it was a game changer. So what crizanlizumab does is, all those sticky places that I told you about, that the red blood cell will attach to in the white blood cells and platelets and even on the walls of the endothelium, and it feels like there's Velcro everywhere, those sticky places get covered with crizanlizumab. It's a p-selectin inhibitor, so it covers over all of those. And so suddenly, I mean, you can imagine like a hallway where people are passing each other, like a school hallway, and all their backpacks have Velcro, right? And as they pass, they kind of stick on each other. And then suddenly somebody puts like, plastic or something over that Velcro, and now they're not sticking anymore. They're able to glide past each other. That's what's happening with crizanlizumab in our system. So yes, because there's less sticking together, then there's less vaso-occlusion or just blockage, right? And so there's less sickle cell episode, and if they happen, they're less severe. So one of the things that actually happened is that my exchange transfusion helped me for 2019 and 2020 up to October, and there was an overlap where I was getting both my exchange transfusion and the crizanlizumab, and then suddenly it stopped. Like suddenly I felt better. And I thought, do I need to still do the, transfusion? And I decided to wait because, they were overlapped. So I didn't know if some of my good feeling was coming from the transfusion and some from the Adakveo or crizanlizumab, or if it was, from the infusion alone and not the red cell exchange. And with time, I started realizing, because I stopped the transfusion, I started realizing I'm actually decent enough. It's not like I don't get crises, don't get me wrong, but they are milder and they are shorter. And, it doesn't get to that point where you feel like pain's coming out your eyeballs and your ears. And, you guys know what I'm talking about, for you that have sickle cell disease and have crises. It doesn't feel like that. It just feels like a chronic ache of moderate pain, and maybe, I know for me, I feel like overwhelming fatigue and the need to just sleep. Like I can't really help it. I just, I'm doing something and I just wake up and realize I've been sleeping. So that kind of thing. But it does drastically, reduced my need for transfusion. And I would hope that it would do that for others too, just based on what it's doing in the body, what the crizanlizumab is doing in the body. My question is, do you need a cross and match each time? Absolutely. In between blood transfusions, you could develop a new antibody. Like if you had, a transfusion last month, and, there was some particular antigen that kind of got through, and your body built antibodies to it. If you don't get type and cross the next time, your body is going to just go after it and just destroy all of your red blood cells that you got, if it has those antibodies on it again. So you don't want to put your system, and that's a huge deal. I mean, you could end up, in a critical state. So yes, every single time you need to type and cross before you have a transfusion. And all the hospitals know that. I mean, it would be a dumb move from any hospital to not do that. So they all know that. I have a problem with sleep, with pain, especially nagging at night. But that's definitely something that we can probably all relate to. And I think a lot of, I know it's a little bit off topic, but I just want to answer real quick. It's definitely not transfusion related, but if you are, it makes sense to have more pain at night because you are having less distractions. During the day, you have a lot of distractions. You can kind of overlook your pain. At night, not so much. So, sometimes you have to increase your pain medicine at night just because of those kinds of things. Yeah. Okay, well, I think it's time. I don't see any other questions, but I made sure to not overwhelm you with slides because I really, really wanted to get this across that you can actually be treated for. And by the way, I got the actual book, and it's like highlighted and underlined. I'm looking for ways out, y'all. So so to manage myself chronically. Yes, by the way, NSAIDs, and another category of pain that people tend not to address is nerve pain. So if you're having pain in a particular spot, ask your doctor for a lidocaine patch and put it on that spot, because you never know, it could actually be nerve pain that then will trigger a sickle cell crisis because it's not being treated. Pouring opiates at nerve pain is like putting the wrong key in the lock. So you're going to continue to have the pain even if you increase the opiates. So you want to make sure that you're covering all the other types of pain with anti-inflammatories and with nerve pain therapies.
Thank you so much, Dr. Simone. Thank you very much for this awesome lecture and introduction with exchange therapy and transfusion therapy services. So we are very, very equipped today with a host of knowledge and resources, where to look and look for, especially when you may be in a situation where you may need an exchange, or a family member may need an exchange, or those doctors that are treating patients, so you know where to get some more information. And just
Yes.
we know that education is key. So thank you so much for taking the time to be present today and share your wealth of knowledge. And I appreciate you so much. If any of you have any questions, you can always message Dr. Uwan through the app. She can always communicate with you. This is a time for engagement, so everyone can actually enjoy the rest of their evening, get engaged. I love to go to conferences, meet people, just say hello. So just say hi to someone, join a chat and get engaged with someone. That's not the end of the conference. Today was a great day, but tomorrow begins another new day of more education. So I thank you so much for joining in. I appreciate you for coming in. I'm so sorry. I thought my camera was on all that time, but I thank you so much for joining in, and I thank you for joining the symposium all together. I hope you can communicate and meet some new people, and also definitely join us tomorrow. I appreciate you once again, Dr. Simone. And I'm going to ask everyone, say a good evening to someone on that post when you're doing engagement. And thank you so much again.
You are very welcome.
You're welcome, Dr. Simone. I don't know if you have to go back to I guess, to put me back as host.
Oh, I don't know how to do that, but you're welcome.
Go to my name. Go to my name.
Okay, so in the participants, okay.
And then at the side, you will see some three dots, and it says
make host. Okay.
Yes.
Okay.
Yep. Thank you.
You are very welcome.
I appreciate all of you. Enjoy your evening and definitely make some new contacts.
Awesome.
Wonderful. Have a great afternoon, everyone.
All right. Thank you, guys.
Thank you, Dr. Uwan.
Okay.
Thank you.